eyes, on your face, in your voice. It's just. Hi, everybody. This is Michelle Dufresne, and I wanted to go over again with you, those of you who I kind of rushed at the end of the tissue integrity lecture. So I'm going to cover the second half, basically, of the content, starting with the descriptors of different wounds instead of pressure ulcers, other wounds. And this is on your outline on slide 42. It begins. Okay, so lacerations, incisions, abrasions, contusions, puncture wounds, and penetrating wounds. Those are the type of quality descriptors I'm talking about. So laceration, tissues are torn apart, the edges are jagged. It's an accident usually. The result of laceration in an incision can be an accident, but it can also be purposeful, like a planned procedure. Abrasion, the scraping of the surface layer of skin. So usually it's an accident, but it can also be a planned procedure, like a dermal abrasion, for example. Contusions are closed wounds and usually are from an accident. Puncture wounds are also considered most of the time accidental, but they also can be planned procedures like biopsies, for example. And a penetrating wound is usually an accident. Okay, so to talk about this a little further on our next slide, classifying types of wounds, we can classify them according to certain descriptors: intentional versus unintentional, closed versus open, acute versus chronic, and then by depth. Acute is defined as a wound that is no older than 2 weeks. So if it's older than 2 weeks, it's no longer considered acute wound. Intentional results from therapy of some kind. Unintentional is usually accidental. Open is breaking the skin. A closed wound is it's closed. The skin is intact still, but injured underneath the soft layer tissues. And in chronic, an example of a chronic wound could be a pressure ulcer. So wound depth includes superficial, partial thickness, and full thickness. So superficial involves the epidermis, and then partial thickness involves the dermis layer. Usually takes a little longer to heal and requires regeneration of new tissue. A full thickness wound involves all the layers of the skin and below it into the subcutaneous tissue. So it's a much deeper kind of wound. An example of that would be a penetrating wound. So our next slide, types of wounds. There are untreated wounds and treated wounds. Untreated wounds, usually the patient or person will show up shortly after the injury. So first aid is required to take care of this wound initially. So you would control the bleeding first, prevent infection, and then control the swelling and pain. Then you can assess other qualities of the wound, like the depth and the type of wound. Okay, so as far as prevention of infection with this type of situation, you want to protect the wound. So we would clean it as best we could, and then apply sterile dressings to cover it and protect it. Ice could be a treatment for controlling swelling and pain, elevating the limb. If it's on a limb, that can be elevated, things like that. A treated wound is a wound that's been treated but has a complication of healing. So they are back. So you want to look at the appearance of the wound, monitoring for signs and symptoms of infection. And HYPER, remember, was the acronym used for that. Monitoring the amount of drainage, the type of drainage, describing that clearly, and then redressing it to, again, protect it from infection or from environmental injury. So on the next slide gives you examples of different types of tissue trauma. Abrasions, ecchymosis or bruising, those are closed wounds. Penetrating wounds, full thickness wound, and partial thickness wounds. On slide 46 is just another example of how to define depth of a wound. So it shows you where epidermis is considered superficial. The dermal layer would be considered partial thickness. And then below the dermis, the subcutaneous layer on down is considered a full thickness wound. Okay, slide 47 is just another example, which now includes pressure ulcers. Remember, we staged pressure ulcers. So comparing that to our depth of wound now, the epidermis would be stage 1. The dermal layer would be a partial thickness, and that's a stage 2. Then the subcutaneous layer, which is a full thickness wound, would be stage 3 on down to stage 4. On slide 48, when it describes how we look at a wound and describe it, we want to measure the size, look at the depth, and look for presence of undermining or tunneling or sinus tracts that can develop with deep wounds. Then we also want to describe the color of the wound bed, any discharge coming out of the wound also. So there's an acronym here that you can use to help you remember how to treat a wound. So red is for R. You see a lot of red, beefy tissue. That's generally regeneration or granulation tissue. So we want to protect the granulation tissue. We protect it by keeping it clean. If it's deep, then we want to fill in the dead space to protect it with different types of dressings that we described already, like alginates and hydrogels for deep stage 3 or full thickness wounds. Then we want to also make sure you're providing the type of dressing that will remove debris from the wound bed to protect it as well. So if you see yellow, then you have a lot of sloughing tissue on the surface of that wound that needs to be cleaned away and removed. So sloughing means we need to have some type of debridement to take place and to make sure we're cleaning it and changing the dressing frequently. We want to use mild soaps instead of harsh abrasive chemicals to clean the wound. The best thing is to simply use normal saline, in fact. So that would probably be your first choice when you're wanting to clean the wound, unless ordered otherwise by the physician. Black tissue means there's dead necrotic tissue on the surface of the wound. That definitely needs to be taken off through debridement of some type, and we've outlined a few types of ways to debride a wound. But it needs to be removed in order for the healing process to continue. So slide 50 just goes over that acronym again. 51 just shows you a picture of the different stages of a wound again and the depth of wound descriptors. So now on page 52, we're going to look at different ways of debridement. So we have surgical debridement, mechanical debridement, enzymatic debridement, autolytic debridement. On 53 is a picture of what a healthy wound would look like. And it's just pointing out what necrotic tissue is and what granulation tissue looks like. And there's some sloughing tissue, the yellow debris on top is considered sloughing, and the epithelial ridge I pointed out. So it looks like white tissue, but that is healthy, brand new skin that's starting to form finally. We need to protect that part of the wound. So different types of ways to debride. So chemically, we apply an agent called collagenase or Sentinel. It's the only agent on the market that is used for chemical debridement. When we apply the chemical debridement on the wound bed, you want to protect the healthy skin that surrounds the wound. That's called the peri-wound, the margins of the wound. So we would put some kind of skin barrier on that area to protect it from becoming too moistened from the heat and the application of this collagenase, the debriding enzymes. So you would protect that area, and that's important to keep in mind. And then you would apply the agent on the necrotic tissue. It will only break down dead tissue. It will not break down healthy tissue. So that's not the concern. The main concern is to make sure we're not allowing the other skin to become macerated and over wet or moistened. Autolytic debridement is, again, what we discussed already. Autolytic debridement was when we allowed the body's own immune system to slowly break down the necrotic tissue. And generally, we would apply a hydrocolloid dressing on top of the wound. And we would do this only if we are sure that this is a clean wound, that there's no infectious process going on in this wound bed. Surgical debridement involves scalpels and scissors, or bringing the patient to surgery in a sterile area and debriding it out. At the bedside, someone who's specially trained to do Sharps debridement would do this at the bedside with scalpels and scissors, and they would actually cut out all of the dead necrotic tissue. Mechanical debridement involves 3 methods. Wet to dry dressings, which is usually today just going to be a temporary type of dressing that you would apply if need be. So wet to dry dressings are okay for a temporary situation only today. Scrubbing, lightly scrubbing the wound when we're doing wound care is a type of mechanical debridement and is needed in wound care. So it's important to be able to apply that light friction on the wound bed to remove the dead tissue away from the wound. Now, you don't want to be too aggressive and scrub deeply and hard, but you do want to apply some friction on the wound bed. Irrigation is the other mechanical debridement that we do. So in irrigation, we would use a 35cc syringe and a 19 gauge needle. And this would apply about 8 psi pressure to the wound bed as you're irrigating it out with the prescribed solution, which usually is saline, but it may be some other substance that's being ordered. Okay. So in some cases, the eschar acts as a protective covering. And then in that situation, it would be dangerous to remove the eschar from the wound. So before we debride a wound, we have to make sure that the extremity or the wound has an adequate supply of perfusion. If it doesn't have an adequate supply of perfusion, then removing the eschar would only open up the wound to infection. So in this case, the necrotic tissue is a good thing, and we're going to preserve it and protect it and leave it on. It's a very slow process to heal a wound, but when we have to, that is what they'll do. When there's not enough perfusion to the area to safely remove the eschar, then we leave it on to protect the wound bed. All right, so then we're on slide 56, nursing interventions to treat infection. So there are several types of dressings on the market that provide antimicrobial action in the dressing. They're impregnated with certain chemicals. One thing is silver, gold is another example, and medical honey is a third type of agent that we would use to help control an infectious process going on in a wound bed. Also, the over-the-counter triple antibiotic ointments, those are also would be used as well, like you would use at home when you have a small cut on your arm or foot or something. So when we clean out a wound, I said we want to use gentle substances that won't disturb or harm the new tissue that's being generated in the wound bed. So hydrogen peroxide, betadine, Hibiclens, and there are several others, are not the preferred solution to clean a wound. So when we want to promote healing, we want to clean it, but we want to use a substance that's safe. These items are cytotoxic to the new cells developing in the wound bed, so they should not be used automatically. Saline, normal saline, is the best solution to use. Okay. Wound vacs on the next slide, 57, is in the outline, and it's just to show you that wound vacs are used to help promote granulation in a wound that's not healing. So generally, chronic wounds might require wound vacs. They're usually huge wounds, and they'll use a spongy dressing to pack the wound's dead space, and then they'll put an occlusive dressing on top and seal it, attach the wound vac to it, and then apply suction. So it actually sucks and draws negative pressure on the wound bed, and that pressure, that suction, actually promotes generation of granulation tissue. So your job would be to maintain the integrity of the sealed dressing. If it does break the seal and leaks, then the suction won't be applied. So then in that case, you would need to remove the dressing and then use a wet to dry type of dressing to pack it and on a temporary basis until the wound vac could be reapplied. So in 58, slide 58, I have examples of drains that are used in wounds. These are used generally in dirty wounds. They come back from surgery with these drains put in place. So there's a Jackson Pratt, a Hemovac, and a Penrose drain. So Jackson Pratt looks like a grenade, and to activate the Jackson Pratt, you have to compress it. It needs to be collapsed, and then it draws a suction when it's collapsed, and will take drainage out of the wound bed. Our job is to measure the output and make sure that the Jackson Pratt remains activated. So if you find one that's inflated, then you need to empty it, measure the output, and reactivate it by collapsing it. Hemovac is a similar device. It's just a little bigger, and it has a spring inside it. So it needs to be collapsed to activate it also, and it'll draw suction to the wound bed in that case. And when you open it, you need to apply some pressure to the top because it's a spring. It opens like a jack-in-the-box kind of. So if you would not have any pressure on the top and open the lid, it would just pop open and stuff might fly out at the same time. So you need to be a little careful when you're dealing with a Hemovac drain. A Penrose drain is the last one. It's in the hand that was surgically placed, and it's a drain that's left open. This drain just drains into a gauze dressing. So this wound would be wrapped in a bulky kind of dressing, and you are expecting to see drainage, and you were expected to change the dressing pretty frequently in the beginning. Okay, so the principles of wound healing now we're at. Principles of wound healing. So intact skin is our first line of defense. Surgical asepsis should be used when we are taking care of a wound, doing wound care, and you learned that the first week of school. The body responds systematically to trauma. It doesn't matter whether it was a planned procedure like surgery, that's still trauma, or an accident. The body is going to respond to it the same way. Adequate blood flow is a necessity in order for a safe, proper wound healing. Also, the wound bed needs to be clean in order for the wound to properly heal. And the response to wounds uh, is effective when there's proper nutrition available. So that's very important. We've talked about those points already throughout this lecture. The next page on slide 60, developmental considerations have to be thought about with concerns specifically about age. So the younger the person is, the more rapidly you expect them to heal. Circulation and oxygenation are a necessity for proper wound healing. So we have to have an adequate amount of blood supply. Nutritional status, again, without nutritional status, we can't produce new tissue to rebuild and heal. So lifestyle needs to be considered also, and it has to do with a lot of different points. I won't break that down, but lifestyle, regular exercise, your weight, smoking, that kind of thing, drug use plays a role in proper healing of the wound. Medications. So we mentioned several medication groups that would interfere with wound healing, like steroids, chemotherapeutics, tricyclic antidepressants, methotrexate for some of our chronic diseases and stuff. So those are all going to impact the way the skin responds to trauma and its ability to heal. The wound condition, of course, is a must. It needs to be cleaned, needs to be protected, and prevent infection from setting in. And then wound stress. So the stress applied to the wound as it's healing will also impact its ability to heal. And what we're talking about are the edges of the wound, in its ability to stay approximated or come apart. So there are certain things that we would try to prevent, like coughing, vomiting, Valsalva maneuvers, activity levels. We want to restrict certain activity levels also. All right. On slide 61, types of wound healing now we're at. So types of wound healing, there's basically three what we call intentions of wound healing. First intention, second intention, and third intention, or tertiary intention. So first intention involves the wound edges being brought together and being well approximated. They're touching in this case. They're supported by sutures, staples, glue. Some method is applied to make sure that the edges are touching and stay together. So secondary intention is when the edges, for some reason, are not approximated, they're apart, and granulation tissue is going to have to build in order for this wound to heal from the center out. The scar will be a lot bigger, and in that case, it takes a lot longer to heal. Tertiary or third intention is a combination of first and second. So it starts off well approximated, and then for some reason, the wound becomes open. And at some point, they will bring the person back in and will bring the edges back together to heal finally at the end through first intention. So it's a combination of both. They start off in second intention and then they end in first intention. So that's what third intention or tertiary intention means. All right, so 62 just showed an example of what first intention was. It's a close, stapled up suture line. Second intention, there was a picture of that, and of an open wound healing through second intention, where the scar is going to be a lot bigger compared to the other example, the first intention healing. And then on 63, there's another page where it's showing a comparison of this first and second intention, where you can see on a thigh healing through second intention, there's no way the edges can be brought together. So, but it's healing very, very well. You can see it's a beefy red picture of a wound on the thigh, and it's doing good, getting healing up with great granulation going on. Okay, so slide 64 goes over the wound healing phases. The first phase begins with inflammation. Okay, inflammation, in that phase, hemostasis has to take place. So initially, the body tries to control bleeding in the area, and then the immune system kicks in. Phagocytosis starts to clean up the wound. So that's what's happening in the first phase of wound healing. We have hemostasis immediately, and then inflammation brings about the white blood cells. So macrophages are our first cells that show up, and then leukocytes come in and finish up the cleaning process of phagocytosis. During that phase also, because of the immune system, we'll have a lot of inflammation, like I said, developing, and the release of histamines occur, and that's when you see the symptoms of inflammation starting, the redness, the swelling, the pain, that all plays a part in the immune system's response to injury. Okay, the next phase is the proliferation phase. And in the proliferation phase, blood vessels begin to regenerate in the area, reestablishing perfusion to start healing and rebuilding new tissue. For example, granulation tissue. The wound starts to close up, and a term that's used for that is contraction of the wound starts to become evident, resurfacing of the tissue as it's building up. New tissue, epithelialization is a term for that. So all the stuff that's needed to build a new tissue is forming in the proliferation phase. Collagen is one of the last things that starts to formulate in this phase. Collagen is what makes the wound strong. So it is part of the integrity of the wound is based on the amount of collagen that's regenerated in the wound. Okay, maturation is the third phase of healing. In the maturation phase, we call it also remodeling. It's the final stage of healing, and in this phase, we will see the scar that forms, and the initial scar forms, and then the body breaks that scar down and rebuilds it, and continues this process of breaking down and remodeling of the scar until it's finished. It can take up to 2 years or longer, depends on the wound, how well it's healing. And the thing about this phase is once it's healed and the scar is there, the strength of that tissue is never the same. It will never be as strong as the original tissue. So this area will always be a concern for breakdown in the future because it's not as strong as the original tissue was. Again, backtracking to the proliferation phase, it begins about day 3 after an injury occurs, and it can last for about a month. And in that phase, one of the more important things to consider is proper hydration, proper nutrition, protection of the wound, so that we can have the normal process of rebuilding new tissue going on. So it's a very vulnerable part of wound healing when we're in the proliferation phase of healing. All right, page 65 goes over complications of wound healing. So infection, we've been talking about infection throughout the lecture, and then hemorrhage. I did hit on hemorrhage a little bit. So initially, hemorrhage needs to be addressed. The body knows that. It automatically wants to promote hemostasis after a wound occurs. So you need to assess the wound for bleeding in those first few days of the injury, after an injury. Infection is something we need to monitor throughout the healing process. And then the major complications are dehiscence and evisceration of a wound. So dehiscence is when a wound opens up. It either totally opens up or it partially opens up. On day 4, 5, it's most the highest risk of dehiscence can occur after surgery. So if we have a person who's coming back from surgery, within that first 4 days, we're really watching carefully for complications of incision opening up. Okay. Evisceration is worse than dehiscence. Evisceration is when the wound is open and now the organs that sit underneath the skin or soft tissue area is beginning to protrude out of the incision site. So people who are prone to having this happen are those who are obese, those who are malnourished, and those who are doing exercises or activities that they should not be doing. People who are, for example, coughing a lot, vomiting, put anything that would put stress on the wound. So if it's an abdominal wound, coughing and vomiting and Valsalva maneuvers will put stress on that wound. If it's a limb, certain exercises that they're doing will put stress on that wound. So those are examples. So either case, they're considered emergency situations. And the first things that you would want to do as the nurse is to protect the wound. And we do this by applying sterile saline and water over the site, and then contacting the physician immediately. It is an emergency situation. That person does need to go back to surgery. Okay, so slide 66, support wound healing. So how do we do that? We do that by maintaining a moist, warm environment for the wound bed to regenerate new tissue. We also want to ensure adequate nutrition. We want to ensure prevention of infection. And then we want to teach them about limiting their activity and proper positioning of the patient. Avoid shearing, avoid friction type movements, and encourage range of motion, independent activity as they can. The next thing we want to do is consider the psychological effects of wounds. Okay, so pain, anxiety, fear, change in body image, all plays a big role in a wound. Our goals, of course, with a patient who has any kind of wound is to prevent injury, prevent complications, and promote healing. Our nursing process through assessment, you'll do, routine care and assess them physically, conduct a general skin overview, looking for the color, erythema, dryness, any areas that are hypo or hyperpigmented. You want to inquire about skin disease, bruising, skin lesions, any acute or chronic developments in their skin condition that's new. Any treatments that they've been using that might be problematic, like sunbathing, skin abrasions, any medical conditions, treatments that they've been doing. We want to assess for ulcers on our pressure areas. Look at those points that are at risk for breakdown. Physical limitation. We want to make sure we're inspecting the pressure areas for any kind of breakdowns. Paying close attention to skin folds also. Looking under medical devices again. And then diagnostic studies, they'll create wounds for us. So those are areas that we need to treat and assess the same way for complications of wound healing. And then independent interventions involving Any diagnostic studies, prevention of infection, promoting hygiene, using mild soaps. Moisturizers are important. Cleaning the wound properly, using aseptic techniques, and then any antibiotic or antimicrobial agents that are ordered to be used on the wounds, and making sure we're using the proper type of dressing for our wound. Collaborative care involves, wound care nurses, the provider, dermatologist, dietitian, physical therapist, oncologist, whoever else is a part of the team taking care of the patient. Pharmacology, therapy, that's the collaborative, intervention. So we would need to follow the orders that are being provided by the provider attending. Non-pharmacologic therapies involve diet, diet high in vitamin C, A, and D, iron, and zinc, use of a wound vac, and things like that. All right, so slide 70 is our last slide, and it is just giving you the major nursing diagnosis that would apply to a patient with any kind of wound. Risk for pressure ulcer, risk for impaired skin integrity, impaired skin integrity, impaired skin integrity, I wrote it twice. Risk for infection or acute pain. So any of these are going to definitely apply to your patient with a wound. So looking for areas that are vulnerable in the skin, over the bony prominences again, any type of alteration in their dermis and epidermal area, you need to pay attention to those areas. Damaged mucous membranes, damage to muscles, tendons, bones, all those things make a person at risk or possibly have an actual impaired problem. Immunosuppressant drugs, and a list of other meds that we went over already. All of these things make it more, important to pay attention to your patient's skin. Okay, so if this is the end of the lecture, if anybody has any questions still, I have opened up a discussion board that starts tomorrow and it'll end Friday. I am going to do my best to address the discussion questions each day, although Tuesday and Wednesday I'm in clinicals all day long, so I may not address the questions on Tuesday and Wednesday. Depends on how late it is before I get home, because it's, I usually get home really late on those days. So I will address each question, though, by the following day, Thursday. So good luck to you, and please let me know how I can help you in the future. Thanks.